This next section is going to be about insomnia and CBTI. I'm excited about this too. Whenever you guys are ready.
Perfect. So, hi everyone. I'm Amin. I'm one of the sleep medicine physicians at the VA Puget Sound, and I'm joined by Dr. Katz. I'll let her introduce herself.
Hi, I'm Kaitz. I'm a clinical psychologist as part of the behavioral sleep medicine team at VA Puget Sound.
And today we're going to be talking about insomnia and cognitive behavioral therapy for insomnia. You can go to the next slide.
Yeah, hold on, my mouse is lost. Okay.
Perfect. And we have no disclosures. We can go right through this one. Perfect. And our objectives today are going to be to define insomnia disorder and what exactly that's defined as, and understanding cognitive behavioral therapy for insomnia, including when and how to refer for this treatment. So what is insomnia? We define insomnia as persistent difficulty with either falling asleep, maintaining sleep, or waking up too early, with your final awakening being earlier than desired. And then this takes adequate opportunity and circumstances for sleep into consideration. So the patient's reported sleep-wake complaints cannot solely be explained purely by inadequate opportunity or circumstances for sleep. And then the sleeping difficulties must cause some type of daytime impairment or distress for the patient. This can either be in the form of fatigue, impaired memory, attention, mood, or even just impaired social or occupational performance. Chronic insomnia is defined especially as sleeping difficulties being present for at least 3 days per week and at least for 3 months in duration. And then it's important, finally, that the sleep disturbances and daytime symptoms cannot be explained solely by another sleep or medical disorder or use of a particular medication or substance. So how might an insomnia patient present? And so Dr. Kaitz and I are going to do a role play where we're going to show you as an example of what an interaction might be between a patient and a healthcare provider. So I'll start. So how's your sleep?
I'm glad you asked because it's actually horrible.
Can you say more about what that looks like for you?
I don't know, I just go to bed and I can't sleep.
How long does it usually take for you to fall asleep?
I think it takes like hours,
And how often does this happen for you?
basically every night.
After you get to sleep, do you wake up throughout the night?
Yeah, any little thing wakes me up and then I'm just lying there again for hours.
How long has this been like that for you?
Um, it's been a few years ever since my deployment.
What have you tried already for your sleep?
I've tried everything and nothing works. I got a sleep study. I don't have sleep apnea. I tried melatonin. I go to bed early. I don't use electronics in bed. I do everything you're supposed to do.
How has this problem been affecting you?
It really stresses me out. I basically can't function. I want to sleep all the time, but I can't.
Do you have anything else that could be affecting your sleep? Work schedule, childcare duties, etc.?
No, I can't focus on anything until I get some rest.
Great. So that's an example of an interaction. And then we can kind of talk a bit about treatment recommendations. So the American Academy of Sleep and VA guidelines recommend cognitive behavioral therapy for insomnia as frontline treatment for insomnia. This should be before medications. Sleep hygiene alone is recommended against for treatment of insomnia. And then just an overview on CBTI. It's usually administered by behavioral or mental health care providers, often psychologists, and this can be in a variety of clinical settings and departments. And the purpose is to address any underlying behaviors or unhelpful thoughts or beliefs that maintain insomnia. It's supposed to address things that medications and sleep hygiene do not. And it usually involves short-term treatment requiring at least 6 to 8 sessions. And this can be either an individual or group format. lately, this has been also available through virtual encounters as well.
So a little bit on the research of CBTI effectiveness. We do have some good, strong research on it, effective in some studies saying 70 to 80% of people with outcomes, including the primary one being decreased insomnia severity, so less trouble falling asleep, less trouble staying asleep. A little bit of research on the impact on increased total sleep time, and a good increase on sleep quality, including objective and subjective measures. We do have some long-term research that even though CBTI is only 6 to 8 weeks, if you follow up with folks 3 months, 6 months, a year later, often those positive outcomes continue to increase. So people's sleep continues to improve. And it is effective in a variety of populations. So older adults, comorbid medical and psychiatric conditions. A lot of people are thinking about chronic pain. That's a big one I get. It's still effective in chronic pain, even when people might feel like, oh, it's the pain, waking me up. Often CBTI still helps there. Oops. I have too many screens now. Okay, some of the components of CBTI, you all probably won't be actually doing CBTI, but just in case, good to know for referring what kind of goes on during CBTI. That B for behavioral approaches, we have a few here. The big one is stimulus control. This is a behavioral technique based on classical conditioning. So we think often of insomnia as something that develops where there's a lot of anxiety or arousal, activation. We usually use that term with patients that develops around sleep and can become conditioned. So you might hear from patients that, I'm falling asleep on the couch, but then I get in bed and I'm wide awake. So that can be a sign that there's this conditioned response. So conditioned stimulus, conditioned response, and we want a good, strong bed sleep relationship. So stimulus control is controlling for those other stimuli that might be getting in the way. So recommendations you might see here are make sure to not be doing anything else in bed. Don't have stressful conversations with your bed partner in bed. Don't worry in bed. Don't try too hard to sleep in bed. So taking all of those things out of the bed to make sure that relationship is strong. And we're also doing some other things to maximize our chances of being asleep in bed. That also means, again, getting out of bed if you can't sleep. It's a big recommendation there. Sleep restriction or sleep compression being the smaller version. We often use the term sleep efficiency training with patients. It's a little bit less scary. This is one of those pieces of CBTI that's a little bit counterintuitive. We're trying to sleep less to sleep more. So focus on sleep quality over quantity. So again, we're trying to maximize our chances of being asleep in bed. We're using the homeostatic sleep drive to our advantage to consolidate sleep, aligning things with circadian clock, all that good stuff. And we're usually setting a specific prescribed time in bed window to do that with patients. But a good starter recommendation is just like, don't go to bed until you're sleepy. Wait a little bit to go to bed. Often people are trying to make up for not being able to sleep by going to bed earlier, which can often be harder. So that kind of changes that. We may also be doing some relaxation skills, buffer zone, wind down time. We all need a little bit of time to transition from our days to sleep time. Again, addressing those like anxiety, things that are coming up around sleep, unhelpful beliefs about sleep. Sometimes you see in insomnia, they wake up and the reaction is like, oh no, I'm awake. I'm never going to be able to go back to sleep. So we may be addressing those kind of beliefs with education or with cognitive therapy, the C part of things, which can include a whole bunch of things, whether that's cognitive restructuring or education or behavioral experiments, really testing out those beliefs. Another cognitive component might be constructive worry time. So taking some of those worries that people might have in bed, if you hear from folks that their mind's racing or they can't turn off through the day, moving that time to another time in their day. And then we might do some sleep hygiene. It can be part of it. It's not all useless for insomnia as well too. If someone's drinking caffeine or alcohol before bed, we'll take those into account too. Okay, so how can we talk about CBTI with patients? We have another little role play for you.
Perfect. So I'll start off as the provider. It sounds like you have insomnia disorder.
Well, I don't want to take any medications.
Luckily, there's a highly effective treatment for insomnia that does not involve any medications. Is it okay if we talk more about that now?
Okay.
I recommend a treatment called cognitive behavioral therapy for insomnia, or CBTI. It's the most effective treatment for insomnia, recommended before medications. It involves working with a sleep expert. They will work with you to come up with an individualized plan that will involve making changes. Some of them may sound counterintuitive at first, but they are effective at treating insomnia and improving your sleep. It usually takes about 6 to 8 weeks of weekly sessions.
I'm not sure. I feel like I already did everything you're supposed to do, like the electronics and going to bed early. I don't know.
It sounds like you've been doing sleep hygiene, which is great and often recommended first, but similar to hand hygiene, it's a great place to start and good habits to keep regularly, but it generally doesn't help people who have chronic insomnia. This is where CBTI comes in and does things a little bit differently. You think of it as more treating the underlying problem and retraining your sleep to get back on track. What do you think? Are you willing to give it a try?
I guess it probably couldn't hurt.
How are you feeling about committing to this treatment and making some changes now? It does require putting in some work outside of your sessions.
I think I could do that.
Okay, any other questions about it?
Nope.
Okay, great. I'll put in a referral for you.
Thanks. Okay. So some things that you could start with patients right away from CBTI. Again, those stimulus control recommendations. So getting out of bed if you can't sleep, sometimes that can be a hard kind of cycle to stop if patients are in bed not being able to sleep and they're just getting more and more frustrated and anxious. Get out of bed, do something else, do something relaxing. Don't try too hard to sleep. Just get back in bed when you're feeling like ready to revisit it and see what happens. Waiting to go to bed until sleepy and using the bed only for sleep. So often that can be a big motivational challenge, but talking with patients about not watching TV in bed, not using, not doing work in bed, those kinds of things, taking those out can be helpful. And then some of that sleep efficiency training. Less is more, aiming for quality over quantity. If you're not able to sleep 8 hours, you don't need to be in bed for 8 hours. And don't try to compensate by going to bed too early or sleeping in or napping during the day, which can perpetuate the problem, make it harder to sleep when you want to. So again, some of the review of things, behavioral strategies for insomnia. Kind of under each category, we're thinking about increasing sleep drive, so physical activity during the day, reducing napping or dozing during the day, and limiting caffeine use. Strengthening circadian cues, so keeping a regular schedule, especially getting up at the same time every day, getting good light exposure in the morning, and avoiding blue light in the evening. And then reducing that activation or arousal component, having a wind down time or buffer zone before bed, stress management techniques, relaxation exercises, and only getting into bed when sleepy. And that healthy sleep environment. So a cool, dark, quiet sleep environment, comfortable pillows and blankets, and limiting substances like alcohol, coffee, and marijuana or cannabis before bed. Okay, so who's a good fit to refer to CBTI? So first, they should meet criteria for chronic insomnia disorder, including, not being related to other sleep disorders, especially sleep apnea is good to rule out beforehand. Willing and able to do homework and make behavioral changes, and medically and psychiatrically stable. So things to maybe not refer for CBTI if they might have other medical or mental health conditions that might explain sleep concerns or get in the way of engaging in treatment. Low motivation or willingness to try behavioral interventions. And then some special considerations. So, there is a rule out for CBTI with shift work disorder, untreated sleep apnea, bipolar disorder, and seizure disorders. But check with your local CBTI providers. Those of us in the behavioral sleep medicine here, we do work with those folks anyway, and we just make some changes to the protocol, but that's generally a rule out. Also thinking about, is it a good time in their life? Most people have struggled with insomnia for a long time. And so a couple weeks, a month, it's not going to make too much difference. And I often, share that with folks. If you've just had a baby, if you've just had a divorce, there's a major stressor right now, maybe wait till later. If you have a surgery coming up, anything like that. So thinking about the timing of CBTI. Yeah. Okay, and referring to CBTI, we did our role play, but I think it's good to start to practice, start to think about how you may talk about CBTI, selling it to patients. We know that CBTI is underutilized often because providers don't know about it, don't know what to say about it, don't know that much about it. But patients are actually really open to behavioral strategies, and some of them may even not be bringing up sleep issues because they think medication's the only answer and they don't want that. So it's good to know that there's something else, be able to share that with people. All right. We're early.
Thanks, guys. Yeah, I think we do have a little bit of time if anyone has questions. Otherwise, we can go to the breakout rooms.
I will ask a question about this definitely, which is, and not everyone may know the answer to this, but in previous sessions that we've had about CBTI, this sounds like a resource that is like fairly accessible at the VA. And I want to know if you guys know much about accessibility in other UW sites. Like how hard is it to get in? And if a patient doesn't speak English, do they have non-English speaking providers? How effective do you find this with an interpreter? I would love to hear some thoughts. Or like, are there community resources that you can refer people to? Any thoughts about that would be fantastic.
Yeah, we didn't include it in our slides, but I think in the resource that we gave you, I think Dr. Parsons put in some referral options in there as well. I don't know if there's anything you want to add about referring to the community.
Yeah, this is a great question, Nikki, because it does come up a lot, right? If you're within the UW system, you should be able to refer to the UW Sleep Center, Harborview. I believe there are wait times. One of the challenges is finding a CBTI provider. I think if you're at one of our tertiary care centers, it's easier. There are community providers, and I provided some of those links in the resource guide. Let's say you leave the UW fold and go hang your shingle elsewhere. You can look online at some of those websites that I provided to try to find a CBTI provider in your area, but you'll probably notice the list can be kind of short. And so my recommendation, if you're outside the UW system, if you have a sleep clinic nearby, ask them, because they probably will be the ones who have already sussed this out. see if they've done some of the work for you of figuring out where these folks may be. There are also people who have differing levels of comfort. So Dr. Kaitz works in our behavioral sleep medicine program, and she devotes her time 100% to sleep care. But there are also some mental health providers who might not be on a national list, but they have done a CBTI training. They can do some basic CBTI. They incorporate that into their general mental health care. So if you have a mental health clinic or mental health providers near you, often you can reach out to them and say, does someone have experience with CBTI? And find those resources that way, because those folks will not be on sort of a national list of DBSM certified people, but they may have experience and they could tell you. I wish it was a little more straightforward to find a CBTI provider. It's a great question. Also, there are digital resources, which we'll talk about in the breakout rooms. It is important for you to think about it. Like, let's say there's nobody, you have no connections at all. You've exhausted your resources. There are some digital self-guided CBTI options available for patients. You want to be a little mindful about referring people to them. And we'll talk about that in the breakout rooms. Be a little cautious about sending someone to self-guided resources, but we'll talk you through that at the breakout. It's a great question.
Awesome. Any other questions about this session so far, guys? Sounds like you revealed all about CBTIs and insomnia.
Completely clear. Thank you. I'll get into that.
Okay, I'm going to open up the breakout rooms, and I've got them on a timer for 25 minutes.
Amazing. And then we'll have a brief wrap up at the end. Thank you, Javel.
All right. Let's see, Hannah, Rima, and Rajuta. It looks like you guys may have gotten kicked out of your breakout rooms. If you could let me know who your facilitator was, then I can get you back in the same rooms you were in before.
Mine was Dr. He.
Thank you.
I was with Rima, with Muna.
You were with Muna?
Yep. And so was Rima.
Ah, perfect. And Hannah, you said Dr. He, right? Yeah.
Yes.
Okay, gotcha. All right. Dr. Kaitz, do you see that there should be a button for you to rejoin your breakout room?
Oh, let's see. I do not see anything. I think I disconnected. Oh, here we go. Thanks.